Hi everyone, and welcome to our Peripheral Artery Disease vodcast titled Understanding Wounds in Peripheral Artery Disease, PAD. In this episode, we're diving into the complexities of wound management in PAD. This vodcast will explore the different types of wounds we often see, like diabetic ulcers, ischemic ulcers, pressure or traumatic ulcers, and venous stasis ulcers, and break down what makes each one unique. We'll also walk you through the essential role primary care providers play in early wound assessment, including the key diagnostic tools we rely on, things like ABI, TBI, X-rays, and lab work. And, of course, we'll discuss why a multidisciplinary team approach bringing together vascular specialists, podiatrists, and other healthcare professionals is crucial to improving outcomes and accelerating healing. This vodcast is part of the PAD National Action Plan, and I'm excited to share insights that can help us all do better for our patients. Let's begin by discussing the types of wounds commonly seen in patients with PAD. First, diabetic ulcers. These are often neuropathic ulcers that occur at pressure points on the plantar surface of the foot. Due to sensory loss from neuropathy, patients may not feel injuries, leading to prolonged exposure to trauma and infection. They appear with calloused margins and may have undermined edges. Second, ischemic ulcers. These ulcers develop as a direct consequence of severely reduced blood flow to the tissues, often due to advanced atherosclerotic disease affecting the arteries supplying the lower limbs. Because of this inadequate perfusion, even minor trauma, pressure, or skin breakdown fails to heal and instead progresses to ulceration and necrosis. Clinically, ischemic ulcers are typically painful, especially when the patient is lying flat, as gravity no longer assists blood flow to the foot. Patients often describe rest pain, which worsens at night and may be relieved by dangling the foot off the bed to improve perfusion via gravity. On examination, ischemic ulcers have a punched-out appearance with well-demarcated borders, and the wound bed often shows dry, pale, or black necrotic tissue with minimal or no granulation tissue. Bleeding is minimal or absent due to poor arterial inflow. Surrounding skin may appear shiny, thin, and hairless, with reduced temperature compared to the contralateral limb. They are commonly located on distal sites such as the tips of toes, lateral malleolus, or heels, areas most susceptible to pressure and shear forces in the setting of poor perfusion. Unlike neuropathic ulcers, sensation is often intact, making these ulcers painful. This pain, combined with physical findings such as absent or diminished pedal pulses and delayed capillary refill, should prompt urgent evaluation for underlying critical limb ischemia, as revascularization is often required to salvage the limb. Third, pressure or traumatic ulcers. These result from poorly fitting shoes or repetitive friction. These ulcers may present in PAD patients. Even minor trauma can progress to non-healing ulcers due to compromised perfusion. Lastly, venous stasis ulcers are wounds that result from chronic venous insufficiency and elevated venous pressures in the lower extremities. They typically develop in the gaiter area, which is the lower third of the leg, especially around the medial malleolus. Unlike ischemic ulcers, these are generally painless unless infected, and patients often report a history of leg swelling, varicose veins, or prior deep vein thrombosis. On examination, venous ulcers have irregular, shallow borders with a granulating wound bed that may exude significant serous fluid. The surrounding skin often shows hyperpigmentation due to hemosiderin deposition, lipodermatosclerosis, and edema. Management focuses on compression therapy to reduce venous hypertension, proper wound care, and addressing underlying venous insufficiency through medical or procedural interventions to promote healing and prevent recurrence. Recognizing wound type is essential to guide management and prioritize vascular referral for revascularization when indicated. Section 2. Primary Care Physician Workup. As a healthcare professional, your role in initial wound evaluation is critical to timely intervention and limb salvage. Let's review what you should include in your workup. First, we need to assess the arterial perfusion. The 2024 AHA-ACC guideline reinforces that clinical examination, including palpation of pulses, does not reliably exclude PAD. Objective testing, for example, ABI, is recommended to confirm diagnosis. ABI and TBI testing is important to order. In patients with history or physical examination findings suggestive of PAD, The resting ABI, with or without ankle pulse volume recordings, PVR, and/or Doppler waveforms, is recommended to establish the diagnosis. Per the 2024 PAD guidelines, TBI with waveforms should be performed when the resting ABI is greater than 1.40, non-compressible. ABI measures ankle to brachial blood pressure ratio and indicates perfusion status. However, in diabetics with calcified vessels, ABI can be falsely elevated, so TBI, toe brachial index, is often more reliable. Typically, in PAD patients, chronic limb-threatening ischemia, CLTI, is more likely with ABI less than or equal to 0.5, but non-healing ulcers can occur at higher ABI levels or with toe pressure and perfusion issues. However, if there are other causes such as venous hypertension or pressure, PAD will exacerbate the ulcer and delay healing. Therefore, it is always important to rule out PAD in anyone with a foot ulcer. Remember, an ABI of less than or equal to 0.5 is frequently associated with critical limb-threatening ischemia. If a wound is ischemic in appearance or does not improve after 4 to 6 weeks of standard care, vascular evaluation should be considered to assess for potential revascularization. And finally, always remember that PAD patients have high rates of concomitant coronary artery disease. Second, X-rays. These help detect underlying osteomyelitis, foreign bodies, or soft tissue gas, suggesting necrotizing infection. If osteomyelitis is suspected, probing to bone can be a useful bedside test. Third, lab work. Anemia can impair oxygen delivery and wound healing. Renal disease is also a risk factor for poor healing in PAD. Serum creatinine and GFR are important if contrast imaging or procedures are considered. Order albumin and prealbumin to assess nutritional status, which directly impacts wound healing. CRP, ESR, and WBC help to detect systemic inflammation or infection. Checking hemoglobin A1C and blood glucose is essential for assessing glycemic control, as elevated glucose impairs wound healing and immune response. Section 3. Importance of a multidisciplinary approach. Healing complex wounds in PAD requires a multidisciplinary team approach. First, vascular specialists play a key role in evaluating blood flow and performing revascularization procedures when necessary to improve perfusion and promote healing. Second, podiatrists are essential for offloading pressure points, performing debridement, and addressing biomechanical issues to prevent recurrence. They sometimes work as wound specialists along with wound care nurses and playing a frontline role in selecting appropriate dressings, performing frequent assessments, and escalating care when wounds are not progressing. Third, endocrinologists are important for optimizing diabetes management, especially in patients with poor glycemic control or complex medication adjustments. Use of continuous glucose monitor to help patients achieve glycemic control will help with wound healing. Fourth, nutritionists evaluate protein and micronutrient intake. Adequate nutrition is vital, as malnutrition is a common issue in patients with chronic wounds and impaired wound healing. Fifth, infectious disease specialists are crucial when there is evidence of deep infection or osteomyelitis. They guide antibiotic selection based on cultures and systemic status. Lastly, other specialists may be called selectively, such as a dermatologist to help diagnose atypical ulcers, vasculitis, pyoderma gangrenosum, that do not follow typical healing trajectories despite optimal PAD and wound care management. Social work and case management to help coordinate home health services, arrange durable medical equipment, DME, and ensure patients have resources for compression therapy, dressings, and transportation to appointments. Multidisciplinary wound care teams have been shown to reduce amputation rates by up to 85%, highlighting the importance of coordinated, team-based care. Section 4. General Principles of Wound Care. Let's review general wound care principles that apply to PAD patients. First, assess perfusion. No wound will heal without adequate blood supply. Always evaluate vascular status before aggressive wound care interventions. Second, debridement. Removing devitalized tissue reduces bacterial burden and promotes healthy granulation. Sharp debridement is preferred when perfusion is adequate or revascularization is planned. Third, maintain moisture balance. A moist wound environment promotes healing, but excessive moisture causes maceration. Choose dressings that maintain balance based on wound exudate levels. Fourth, offload pressure. Use total contact casts, orthotics, or specialized shoes to reduce pressure on the wound site and prevent further trauma. Finally, patient education is critical. Encourage daily inspection, proper foot hygiene, and avoidance of barefoot walking to reduce injury risk. Section 5. Staging, neuropathic versus vascular, dressing types, support shoes. Now let's talk about staging wounds and differentiating neuropathic from vascular ulcers. Wound staging involves evaluating depth, tissue involvement, presence of exposed structures such as tendon or bone, and infection signs. An important tool for assessing ischemic wounds in PAD patients is the WI-FI classification system developed by the Society for Vascular Surgery. WI-FI stands for wound, ischemia, and foot infection, and each category is graded from 0 to 3 based on severity. For wounds, grade 0 means no ulcer but a high-risk foot, while grade 3 indicates extensive deep ulcers involving the heel or midfoot with significant tissue loss. Ischemia is assessed using ABI and/or toe pressures, with grade 0 indicating no ischemia and grade 3 indicating severe ischemia, such as a toe pressure less than 30 millimeters of mercury. Foot infection ranges from no infection at grade 0 to severe infection with systemic toxicity or metabolic instability at grade 3. The WI-FI classification helps predict the risk of amputation and the potential benefit of revascularization, guiding clinical decision-making and ensuring timely intervention. It also standardizes communication among providers and helps set realistic expectations with patients regarding their limb salvage prognosis. Neuropathic ulcers often have calloused borders, are painless, and occur on weight-bearing areas. In contrast, vascular ulcers are painful, located on distal toes or pressure points, and have dry, necrotic bases. Dressing types should be selected based on wound characteristics. For dry ischemic wounds, maintain a dry environment if revascularization is not possible. For moist wounds with exudate, use absorptive dressings like foam or alginate. Hydrogels can rehydrate necrotic tissue pre-debridement. Finally, good supportive shoes are vital to prevent further injury. Recommend well-fitted shoes with extra depth and width, avoiding tight toe boxes, and consider orthotics or total contact casts when indicated. Thank you all for participating in this vodcast. We've covered numerous critical aspects of peripheral artery disease, and your contributions will have a significant impact on the PAD community. In closing, I'd like to remind everyone to encourage your patients to play an active role in their medical care by advocating for themselves and their family members. For additional information, please visit the AHA's PAD for Professionals website for more educational resources. Thank you.